Good morning, everyone. I'm Dr. Hong from Chung-ang University Hospital. Thank you very much for giving me this great opportunity to present in front of all of you. Today I'm going to talk about apical myectomy. I think the most commonly used myectomy approach is transaeric approach. As you can see in this picture and video, the aorta is opened, and through the aortic valve, the basal septal hypertrophy and sometimes midventricular hypertrophy is resected. But today we are talking about apical hypertrophic cardiomyopathy, and I think we don't know so much about apical hypertrophic cardiomyopathy and apical myectomy so far. But one thing that I would like to mention today is that apical hypertrophic cardiomyopathy is not as benign as we thought before because of debilitating symptoms from advanced heart failure and life-threatening complications. And because of those, I think apical myectomy has for sure certain role to treat patients with advanced apical hypertrophic cardiomyopathy and heart failure. This is Dr. Schaff from Mayo Clinic. He looks very young in this picture because it's about 10 years ago. We invited him to Seoul, Korea, and then he gave us wonderful talk about hypertrophic cardiomyopathy, including apical myectomy. It is almost impossible to talk about apical myectomy without mentioning Dr. Schaff's paper. This paper is published about 10 years ago, and as you can see in this picture, the apex of the heart is lifted up, and then an incision is made on the apex, and then through the apical incision some part of hypertrophic muscle is resected, and then the apex of the heart is closed. In this paper, I think Dr. Schaff's group very nicely described physiologic change before and after apical myectomy surgery. As you can see in this panel, ejection fraction decreased after apical myectomy surgery in most of the patients. But as you can see in this other panel here, the left ventricular stroke volume increased after apical myectomy surgery, and I think also cardiac output is increased after apical myectomy surgery. This positive physiologic change after apical myectomy is achieved from increased left ventricular cavity size. So simply, we don't treat left ventricular obstruction, or we don't treat decreased ejection fraction in patients with apical myectomy. Mostly we treat endodiastolic dysfunction with apical myectomy surgery. When we talk about apical myectomy surgery, I don't think it's a good idea to focus on the change of left ventricular ejection fraction. This is not exactly the patient with apical hypertrophic cardiomyopathy. This is the patient that I operated on a couple of years ago. This patient had debilitating symptoms from decreased left ventricular cavity size with diffuse hypertrophic cardiomyopathy. And before myectomy surgery, ejection fraction was 61%, and after myectomy surgery, the ejection fraction was 39%, and I was criticized from one cardiologist in one conference in Korea because of this decreased ejection fraction. But here, we don't treat the patient's ejection fraction. We treat patient left ventricular endodiastolic dysfunction, and through the myectomy surgery, even the ejection fraction is decreased. As I showed you in Dr. Schaff's paper before, the patient's stroke volume and cardiac output increased, and because of that, patient symptom gets better, of course. And I think this is very important concept of apical myectomy surgery as well. This nice picture is taken in 2015 when we are doing some research together. And another picture of Dr. Schaff and me in 2018 Tokyo. And this is Dr. Takanashi, who hosted this nice conference, and this is Dr. Wang from China. We were trying to build Asian myectomy group at that time, but because of COVID-19, everything has stopped. And time to rebuild our relationship is coming, I think, very slowly though. Dr. Schaff added about more than 100 patients of apical myectomy, and they compared patients who are on heart transplantation wait list and patients who underwent apical myectomy, and patients who underwent apical myectomy showed better survival comparing to patients who are on wait list. This picture describes a patient who might need combined transaeric and transapical myectomy. But nowadays, even if the patient have basal septal hypertrophy and also midventricular hypertrophy, many groups perform myectomy surgery only through the transaeric approach. This picture is from European Journal of Cardiothoracic Surgery 2018, and they suggest that basal hypertrophic cardiomyopathy and midventricular hypertrophic cardiomyopathy can be treated only through transaeric approach, and I totally agree with them. Those pictures are from a paper published by my center this year. This is not exactly about apical myectomy, but when patient has complex left ventricular anatomy, including midventricular obstruction, because of limited view through the small aorta and aortic valve, we used thoracoscope. So through the aortotomy, we put 5mm scope of 30-degree camera angle and inspect inside of the left ventricle with the scope, and then we perform surgical procedure. And through this approach, we could perform myectomy surgery in patient with very complex left ventricular anatomy and patient with midventricular hypertrophic cardiomyopathy safely. This is good example of video scope-assisted transaeric myectomy. In this patient has very diffuse hypertrophy and midventricular hypertrophy as well, and thickened papillary muscle. So through the aortic valve, it's very difficult to see inside of the left ventricle, but when we use video scope, we could see inside of the left ventricle better. But even with video scope, as you can see in this picture, we could see only tip of the papillary muscle, but after some part of septal hypertrophy is resected, we could see the base of papillary muscle, and after this video we resected more part of hypertrophy, and then patients discharged very safely. Other approaches to treat apical hypertrophic cardiomyopathy has been tried as well. This is transmitral myectomy. An incision is made on the left atrium, and again the left atrium is opened, and then again another incision is made on the anterior leaflet of the mitral valve. Good thing of transmitral myectomy is that it can be performed with minimally invasive surgery. But again, as you can see in this picture, it leaves long incision and suture line on the anterior leaflet of the mitral valve. And it is almost like another mitral valve surgery. But so in many centers, this approach is saved for pediatric patient or adult patient with very small aortic annulus, or patient who might need combined mitral valve surgery because of intrinsic mitral valve abnormalities. There are many subtypes of hypertrophic cardiomyopathy. and this is normal. This is basal septal hypertrophy, and I think those two subtypes can be treated with transapical approach. Again, in this picture, patient has only apical hypertrophic cardiomyopathy, and I think this case can be treated with apical myectomy. But in this picture, patient has basal septal hypertrophy and apical hypertrophy as well. So I think this patient should be treated through a combined transapical and transaeric approach. But when we think about this subtype of hypertrophic cardiomyopathy, patient may have left ventricular outflow tract obstruction because of basal septal hypertrophy, and also patient may have endodiastolic dysfunction because of apical and midventricular hypertrophy. So what if treat this patient with only transaeric approach? Because as I showed you in previous slide, through the transaeric approach, we can resect basal septum, septal muscle, and also we can resect midventricular septal muscle as well. So through this approach, we could achieve two goals. One is relieving left ventricular outflow tract obstruction, and also increasing the left ventricular cavity size to treat diastolic dysfunction as well. This is my summary. As I told you before, apical hypertrophic cardiomyopathy is not as benign as we thought in the past because of many symptoms and because of possibility of developing advanced heart failure. So patient with apical hypertrophic cardiomyopathy with heart failure can benefit from apical myectomy surgery. And again, apical myectomy is not to increase ejection fraction, is to increase left ventricular endodiastolic volume and to increase left ventricular cavity, stroke volume, and cardiac output. And to resect apical hypertrophy, transapical approach is mostly studied so far, but as I showed you before, there are other approaches are being tried. And I don't think we know much about apical hypertrophic cardiomyopathy and apical myectomy surgery. So I think further studies required about optimal timing of surgery and optimal surgical approaches as well. Thank you very much for your attention. Thank you.